I think there's an echo.
Everyone else is muted here. Yeah, so I'll be presenting this case that was done with Dr. Graywall and Dr. Chalk. Let me see who I can pick on so no one picks on me. Carlos and Diogo. Okay. So we have a 68-year-old male with difficulty walking for a year, and also complains of some memory deficits that are pretty non-specific. Carlos, are you on the line?
Yes, I'm here.
Yeah, what do you want to do next?
So the memory deficit is just for 1 year as well?
Yeah.
Time?
Yeah.
So I will perform a full physical examination and with more interest on what type of gait he's presenting with.
Yeah, that's really good. So next slide. So when you he's basically intact, but when you examine his gait, you can see that he had a broad-based gait, and he took about 5 steps to turn like completely 180. And this sort of it's a very like non-specific and non-focal exam. Some things you think about at this point is, is it something something like hydrocephalus can cause this, or cerebellar ataxia is another mechanism in which you can get broad-based gait. Basically, the patient is trying to find balance in their gait, and they're attempting to do so by having both of their feet planted wide apart. Okay. So what do you want to do next? I think I have it here. I want to get imaging. All right. So this is the T2 axial. Let me try and stop this right here. And this is sagittal with contrast. And there's a Professor Montaser online.
Yes, I'm here.
Yes, sir. Can you, if you're able to see the imaging, could you tell me or describe to me what you saw?
Well, I see there T2 on the left and then sagittal T1 precon and maybe postcon the bottom left as well. And it looks like a diffusion on the right hand side. So I see a high signal intensity lesion in the kind of I would say the connection, between the lateral ventricle and the third ventricle. I'd like to see a coronal if possible to kind of like confirm that it's kind of like the foramen of Monroe right there. It's hyper intense on T1 and hyper intense in T2 as well. I didn't see like major enhancement. And then the diffusion, could you scroll in the diffusion as well a little bit, please?
Yeah, this one doesn't scroll. I'm sorry, I tried to download it, but it doesn't.
Yeah, it does show diffusion restriction. I'd be happy to see an ADC map just to confirm that it's a diffusion restriction, not just a T2 shine through. But it's right there, obvious on the axial diffusion. Actually, that's the most obvious scan for me. Just right there at the right foramen of Monroe. Kind of like measuring, let's say, a few millimeters, maybe 5 or 6.
All righty, thank you.
There's also, yeah, I think, how old is the patient again?
68.
Yeah, I mean, that goes, the ventricular size goes with a 68. I wouldn't call it hydrocephalus, actually, although it's a bit dilated.
All right. So the differential for that mass would be, I think you mentioned already, a colloid cyst. If you were thinking about, hydrocephalus, there may be 2 things going on with this guy. So on top of the possibly communicating hydrocephalus, on top of the non-communicating right at the right frontal horn, because I think the rationale was that, you see both of the, if we are considering hydrocephalus for this patient, which I thought it was, you know, that colloid cyst wouldn't really explain both frontal horns and all the ventricles with the, given the size of it, it wouldn't really explain just one side being blocked at the right foramen of Monroe. Yeah. So the assessment plan for this patient, we decided to do a endoscopic approach for the resection of this mass lesion to see how the patient does.
James, hold on there.
Okay.
All right. So if someone has difficulty walking and hydrocephalus and this colloid cyst, would you recommend resection?
No, I would have, what my thought was perhaps just try a VP shunt first, because if I was thinking that, you know, if this colloid cyst was incidental and I didn't think that it was causing any blockage, then, you know, I would try a shunt first to see how the patient does, left-sided.
So was I just an idiot?
No, sir, I'm just an idiot. Maybe I'm not understanding something.
Oh, I'm trying to understand. You're moving to a surgical procedure for a cyst, and you haven't really told us why.
The right frontal horn is slightly bigger than the left.
No.
So I wanted to, yeah, sorry.
All right. So part of the history that's left out here is that over the past 6 months, he had 2 episodes where when he became exertional, he blacked out. Okay.
Oh, I see. Yeah, I didn't catch that.
That's a really important part of the history here, because what can happen with colloid cysts?
This can like have a ball valve effect where it causes acute hydrocephalus and cause a herniation. So that's not what you want to happen. Right.
Yeah. So that's telling you that maybe he's intermittently obstructing when he's exertional. We did a cardiac workup to make sure this wasn't incidental prior to this, right? And then he has 2 different things. So we talked to him beforehand and we said, look, we need to take care of this colloid cyst first because we think that's the more life-threatening problem. We don't think this is going to help with your walking. We think you have normal pressure hydrocephalus. Allah, you didn't think he had normal pressure hydrocephalus based on his age and his ventricular size. What other findings on an MRI would point you towards normal pressure hydrocephalus, or hydrocephalus for that matter? Are there other metrics you can look at?
I don't think I put it on, but I should have put on the sequence that perhaps shows a transependymal flow.
No, sure, transependymal flow, but I was asking Allah.
Sorry.
Yes, Dr. Graywall. I checked for the transependymal flow, if there is any. And usually, actually, the history is kind of like leading me to kind of like, go along with the idea of a normal pressure hydrocephalus given the age and the gait apraxia and maybe some urinary symptoms. But again, with that colloid, go ahead, please.
On imaging alone, what else points towards hydrocephalus? What else are other metrics you look for?
The normal pressure hydrocephalus, it's communicating hydrocephalus. Let's see, maybe some transependymal permeation.
So have you guys heard of the Evans ratio?
No, I'll look that up.
Okay, all right. So you want to look up what an Evans ratio is. The other thing is you look at the callosal angle. So that's done on coronals, and a narrow callosal angle will point you towards that. Finally, is there something that's very specific in normal pressure hydrocephalus that's an imaging finding that this person clearly has? Maybe one of our senior residents can help you out here if they're listening.
Hey, Dr. Graywall, it's Kelly. Can you hear me?
Yeah, hey, Dr. Gasson.
I kind of came in and out because I was dealing with a patient issue, but if you're asking about other findings in normal pressure hydrocephalus, this patient has, you do what?
Just on imaging.
No, they typically have widened sylvian fissures, and can have actually wide sulci, you know, on the cortical margins. But this patient does seemingly have this based on just my view here on my phone. But their sylvian fissures look pretty expanded.
Right. So there's this thing called DESH, right? DESH, which is radiologic finding that's very consistent with normal pressure hydrocephalus. So that's diffuse enlargement of subarachnoid spaces in hydrocephalus. So what you see is the lower subarachnoid spaces, such as a sylvian fissure, are wide and open. But when you look up high towards the vertex, so James, scroll up, right? So up towards the midline of the vertex, you see how they narrow. Okay, so you have narrow, crowded up top and wide below. And that's very consistent with normal pressure hydrocephalus. So you know, preoperatively, you counsel this patient, hey, we're going to take care of this colloid cyst because we're concerned that you might be intermittently obstructing, but that's not going to help you. What's ultimately going to help you is probably a shunt. And before we consider a shunt, we'll do a lumbar puncture to really make sure that you benefit from that. But the first thing is to take care of the colloid cyst. So you can now proceed with your approaches to a colloid cyst resection.
Yes, sir. So let's see. Can you see the video okay? I'm going to skip some areas. Let's see here. So we did this with Dr. Talk. We put the patient supine, head or bed, you know, reverse Trendelenburg. We put a burr hole in the right frontal area. And we first put in the EVD. And after that, we used that same tract to enter with the Meinhof scope. And let me see here if I can show you the anatomy. So right here, we know that this is the right side because we can see the directionality of the choroid fissure here. This is the fornix, this is the thalamostriate vein, this is the anterior septal vein. And let's enter, when we go deep through that.
So Dr. Gassi, you're looking here and you don't see the colloid cyst. Is that what you expected based on the MRI?
I'm sorry, I'm in the OR. I'm intermittently coming in and out. I think somebody mentioned you said my name.
Oh yeah, I was just saying. Look, so you're getting into the third ventricle here through the fornix, and you're not seeing the colloid cyst. Would you expect not to see the colloid cyst, or are you freaking out? What's going on?
Let's see. You don't see the colloid cyst at all?
I don't know if you see it.
Well, I would probably, so on my way in, I didn't visualize it either. Is that what, at all?
Correct.
Okay. I'll have to go back and look, and the colloid cyst typically will fill that, you know, bilaterally, you know, where you're coming in through the foramen, but I would look, it's not hidden or a little bit more posterior, but typically you see it when you come in. I would be, you know, again, make sure I'm in the correct ventricle, even though I would expect to see it coming from either, I'm not crossed, I'm coming down through the foramen.
So James, can you pull that MRI up again?
Sorry, I'm in the operating room, so I missed a couple things probably.
No worries. So Kelly, if you look at that top right image, right?
It's pretty posterior.
Exactly, right? So it's pedunculated, right, as a colloid cyst would be, but you can see it, especially if that's supine, it's going to want to fall back, right? So
yeah, and if you're having a rigid endoscope, you know, I think you'd have to, you know, going into the case, you know, looking posteriorly, you'd have to consider that. So I think at this point, if you're able to look a little bit more posterior, I don't know how you position the patient to where you can get that angle.
James, go back to the video. So if you're seeing this, what do you think is going to be your next move to try to find it?
Well, I would probably pull my scope in just a touch deeper. I see the mammillary bodies. I see there's a lot of choroid plexus here. The thing you have to watch out for is, you know, if you're looking posteriorly, you have to be very careful to retract against the fornix, you know, anteriorly. I think that would be a problem, but I would probably go in a little deeper or try to angle a little bit, you know, hand to anteriorly so I could look just a touch posterior.
Yeah, so you said it just correctly, right? But if you do that, you're going to ding the fornix, and you don't want to do that. So is there a way you can get access more posteriorly without angling?
I mean, not unless if you go through the foramen, there's no way you can go posteriorly. If you're going, like when you're going into the third ventricle, you can, you know, find the vein and find the thalamus. I think the choroidal fissure, from what I understand, but I think I'd have to plan for that before surgery. I don't think I can get there with my endoscope just looking. You'd have to back out and come in more posteriorly, medial to the thalamus, and you know, as if you were going to go just directly into the third ventricle with through the fissure.
Right. So Talk, Olu, and I published a series where you open the choroid, right? So that you can gain access to more located lesions. So that's the next step, and James can walk you through how we do that. James goes through this. So you see the choroid plexus there. What you're going to do, you're going to coagulate the choroid plexus. You can just start to see the hint of it right there. Keep going, James. Yep. So you're going to coagulate and resect choroid plexus. Keep going. Going. Now, as you're resecting choroid plexus, you start seeing, what are you starting to see there? James, anyone? Right, where are we working right there? So that's the venous angle, right? So that's where your thalamostriate and septal veins meet. And you can usually split right into there, making sure that you're avoiding damage to the internal cerebral veins, which are going to be deeper to this of the telochoroidea. Go in, but you can see how you're starting to enlarge that fissure posteriorly so you can get a better angle towards this. There you go. Now you can often take that vein right there that's splitting between the two. That's just a branch. We try to work around that because Dr. Talk doesn't like veins being taken.
Sorry, Dr. Graywall, my audio stopped working, so hopefully you can hear me now. So that's the colloid cyst that we see right here.
It's right under that vein, right?
Yeah, and that's the venous angle. Yeah. Let's see here. So I'll fast forward a little bit. Now, what we do here is we try to take a piece of it because you don't want to just rip it out there because there's a lot of venous feeder, or there's venous plexus there as well, and you don't want to have a lot of blood in the field. So Carlos, sorry to keep picking on you, buddy. So what happened? What should you do if you encounter a bleeder and you can't see anything? What do you do?
So you keep trying to find the source of the bleeding, to coagulate it. And I believe you should irrigate as well, just to make sure you stop the bleeding as well.
Yeah. And as Dr. Graywall taught me, this has to be like a two-surgeon sort of deal. I'd be pretty useless trying to help Dr. Graywall in this, so that's why he needed Dr. Talk.
Yeah.
So here we.
If you're going to do this endoscopically, you really want 4 hands working together. You know, you could do this again. There's multiple open approaches where you can get both your hands in, and then you don't need to struggle as much. But if you're going to do this endoscopically, you really want to have 4 hands, because the camera operator and the instrument operator need to be working in conjunction, so you understand what's going on. Now, you know, when you're not taking it out in block, it's really important that you suck up all that colloid, because what can you cause if you leave that protection material in?
That's going to clot off, or it's going to block the cerebral aqueduct, I believe.
Right, it can block off the aqueduct, or it can cause aseptic meningitis in these patients, okay? So this is like a little pediatric NG tube that we insert through the working channel as our suction device.
You know, was there any concern for me? It looks like a small lesion. So that anterior septal vein, you guys were able to work and preserve that. I would imagine a larger colloid cyst you guys would have seen anyways through the foramen, but you know, is there any harm to take that? I'd worry the whole case I was stretching that, you know, vein and that it would rip, you know, during the resection of the colloid cyst. But were you guys able to preserve that and just work through that? Or was there any
We actually had
discussion?
to, if I remember correctly, we had to actually sacrifice the connection between the anterior septal and the, basically the venous angle, to kind of get that more of an angle towards that colloid cyst.
So
yeah, because it looked like that vein was that septal vein was it was small, looking a little stretched. I didn't know if you guys ended up taking.
So that wasn't the septal vein, guys, right? So the septal vein, that was a tributary off the septal vein. So remember, at your venous angle, you're not going to have the septal vein join the glemostride directly as a 1-to-1, okay? You have multiple branches there. So that anterior branch that was looking really thin, you can take really with the community, okay? The septal vein's up there where James is pointing.
I think it was earlier in the video that maybe I was looking at. There was a smaller, very small vein.
Right, exactly. That's one of the connections between the glemostride and the septal, and you can take that without a problem. And most often, you can even take the septal without causing a problem. James, go through the video. Scroll to the video. I'll show. I know exactly what Kelly's talking about. Nope, too far. Come back. Go way back. Way back. Way back. Way back. Way back. Keep coming back. Keep coming back. Keep coming back. Keep coming back. Right there. Stop. Go a little bit forward. Go a little bit forward. Right there. That's the vein you're talking about, right, Kelly?
Yeah, that was the original one that I was thinking of when you guys were working, but behind that little area behind that. I don't know if you guys ended up having to take that.
We did, yeah. Talk tried to save it for a little bit, but eventually we took it. You can take that without any issues.
Thank you. That's really helpful.
Yeah. All right. So at the end, you saw that we took the rest of the capsule out, and then we can move on for time here.
Yep. Okay. So this was the histology. You can see stratified columnar epithelial cells. That's pretty diagnostic of colloid cyst.
And Dr. Gentot is on the line, I think.
Oh, sorry about that.
Yeah,
Yeah.
You can see a simple epithelium here, highlighted by the arrows. And then just on the right-hand side is the cyst contents. It's just proteinaceous acellular debris. So it's a classic colloid cyst.
So on post-op day 1, after the resection of the colloid, we put in an EVD. EVD was clamped on post-op day 1. CT was stable. EVD was removed on post-op day 2. Discharged on post-op day 3. On 1-month follow-up, the gait significantly improved per Dr. Graywall's note. But he comes back in 2 months later with unsteady gait again taking 5 steps to turn 180 degrees. The next step, we got a CT scan. This was before, and this is after. So you can see the vents are slightly bigger. So the VP shunt was placed on this month. Discharged on post-op day 1. And I think 2 weeks following, also in clinic, the patient was doing much better in terms of gait. So that's pretty much it for now. Thank you very much.
Good job, James. And yeah, it was a nice discussion, everyone. I appreciate any additional thoughts anyone has on this case. But, you know, you have to understand their symptoms beforehand, and you have to counsel these patients, right? Why do you think his gait improved after the first surgery?
The gait improved because, you know, when we're doing the surgery itself, we're releasing some CSF. And let's see, we didn't do a third.
No, but you're releasing a lot of CSF, right? So if you look at his immediate post-op scan, he actually has a little hygroma.
Yeah, like
you expect, right? So
yeah.
so right, and that's why the ventricles look smaller, because you basically created a fifth ventricle for him. With that connection, and once that reabsorbed, his ventricles went back to his initial size, and his walking was poor again, which is okay because we had told him that beforehand, right?
Yeah.
And he knew that the shunt was what was going to help him, and he's done quite well. So
Gotcha.
All right. Well,
thank you.
James, if you can just stop sharing so I can show the flyer for next Monday. All right. So everyone, thank you all. Next Monday, we're going to have Dr. Stipler. She's an assistant professor from Harvard. She's going to be talking about follow-up PET-CT in complicated mild TBI patients. Sorry about that. And before that, we're going to have our traditional BNS with Dr. Olomo, and then Dr. Quinones will be giving the updates. So thank you everyone for joining, and we'll see you Monday.
Another great conference. Thanks, everyone.
Thanks, sir.